Hi, Dr. Ted and Dr. Rhonda. Welcome to the Philippines. I'd like to ask, what could be possible causes of vitamin deficiency for people who've been taking high levels of vitamin D supplementation and yet the vitamin D remains to be deficient?
Fantastic question. I didn't get into those mechanisms this evening, but there are a couple of gene polymorphisms. So if you remember that slide I showed you, vitamin D, you make vitamin D from the sun, for example, or if you take vitamin D3, which is essentially the same form of vitamin D that your skin makes, the vitamin D3 has to be converted into 25-hydroxy vitamin D3. And the enzyme that does that in the liver is called CYP2R1. And that enzyme, CYP2R1, there are several different polymorphisms in that gene, which essentially just means variations in the sequence of DNA in the gene, because people are all different, and those variations can lead to functional consequences. In this case, it doesn't do it as well. And so people that are supplementing with vitamin D3 aren't converting it into 25-hydroxy vitamin D3 very well, which is the proxy that you measure. And I know actually several people that have that specific polymorphism, and they have to supplement with much, much higher levels than would be considered normal. So that's one possibility.
Well, vitamin D needs to be absorbed with oil, something fatty. Will this work with any type of oil, or do we have specific types of oil? For instance, is it equal if you use plant-based oil and if you use meat-based oil for taking in vitamin D?
So as you mentioned, vitamin D is a fat-soluble vitamin, and so having fat with your vitamin D does increase the absorption. I'm not sure about if the type of oil matters. I don't know if it does or not. I would speculate it shouldn't, but I'm not sure.
Well, thank you, doctor. Thank you.
Is there a symptoms, physical or that will point to a lack of vitamin D? Symptoms to vitamin D deficiency.
So the symptoms are, I would say, probably that would not be the way to diagnose vitamin D deficiency, because the symptoms of vitamin D deficiency are so broad. They overlap with symptoms of many other possible causes. So I don't think that would be a real accurate way to assess vitamin D deficiency or insufficiency. So the best way would actually be just to measure blood levels. So it's something that's quantitative, that we know for sure, okay, this level of vitamin D is important. It's associated with a lower all-cause mortality, for example, if you have this level between 40 and 60 nanograms per milliliter. I don't really think, unless someone comes in with rickets, which is a severe vitamin D deficiency, I'm not sure that symptoms would be the best way to assess vitamin D deficiency.
To add to that, I always say when I lecture about vitamin D is that the genes, the gene themselves that are involved in vitamin D production, it's very old. It's over 500 million years old. It's found in single-celled organisms. So it's essential to our survival. So you don't go by signs and symptoms of deficiency because it's involved all over the body. So you'll have protein signs and symptoms. And so you don't go by that. You have to go and take a look at the levels for your patients.
Okay. Second question is, is there really published clinical data that will point to evidence showing that adequate levels of vitamin D can actually help prevent chronic diseases? Or because we did some search ourselves and we found that there is no direct correlation. That most of the studies really just say that having enough vitamin D links to lesser chances of getting chronic disease, but there's really no direct evidence showing that having enough will prevent you from getting chronic diseases.
Yeah, so there was 33 different studies that were published from 1966 to 2013 that measured vitamin D blood levels. and looked at associations with all-cause mortality, right? So those people that had blood levels between 40 and 60 nanograms per milliliter had a significantly lower all-cause mortality. So they died less of cancer, neurodegenerative disease, respiratory disease. They didn't die as early in life as people that had blood levels that were lower than 40 nanograms per milliliter. But in terms of people doing randomized controlled trials where you're actually giving people supplementation to see what effect it has on a certain, for example, on cancer incidence or on, bone frailty, things like that. There have been studies showing that it does improve, for example, bone frailty. The problem with these studies are many times vitamin D supplementation is not given at a high enough dose. Because people are different, because people have gene polymorphisms in their CYP2R1 gene, for example, you have to measure vitamin D levels after supplementation to know if you're actually even moving the needle at all. And a lot of clinical studies do not do that for reasons of funding. It's just too expensive for some of these studies. They don't measure blood levels in all these people. And so if you give someone a supplement that's 400 IUs of vitamin D, it's not going to really do much. So you really have to look, when you're looking at the evidence, you have to make sure you're looking at a study that has been designed properly and not a poorly designed clinical trial. Because of this reason that, when you're looking at nutrition, when you're looking at vitamins, for example, everyone's different. We all have different diets. We all have different sun exposure. We're different ages, different melanin. Some of us wear sunscreen, whatever. So when you're measuring a nutrient like that, or vitamin D, for example, you have to measure it. So if you're just looking at a disease outcome and you say, okay, here's a person, we gave them vitamin D, and all we're looking at is cardiovascular disease incidence, but we didn't measure their blood levels, you don't know if you actually did anything. They could have been so deficient in vitamin D, they could have been 10 nanograms per mil, and you gave them 800 IUs. We know it takes 1,000 IUs to even raise blood levels by 5 nanograms. So when you're looking out in the literature, you really have to look at the methods. You have to look at how the trial was designed. So that, I would say, the studies that you're referring to that you would look at, I would go back and see, was this a good study? Was this a good study design?
But in your search, have you come across such studies with good designs that will point to the evidence of vitamin D and its link to cardiovascular or other chronic diseases?
Yeah, so for example, there's a study that was published 2006, I believe, that showed vitamin D supplementation along with calcium supplementation decreased colon cancer incidence in patients, actually in patients that were genetically susceptible to colon cancer. So I think that would be one example of is that the kind of study you're asking about?
Yes.
Okay.
But are there others?
Yeah, of course. Yes, there are. I mean, there's studies out there showing that there is an effect, and there's studies out there that are showing there's no effect. And like I said, it all comes down to looking at the study, looking at the trial design, looking at what was measured, was anything measured, did they even show that giving them whatever dose they gave them actually increased their blood levels? Because if they don't show that, and they have a negative, you're looking at a clinical outcome and there's a negative result, you don't know. You have to quantify something to know if it's working. So, I mean, there's studies out there showing both ends of the spectrum. It just all depends, I think, on many different other factors.
I've been giving vitamin D supplementation to most of my patients who are infertile and who have polycystic ovarian because of the journals that came out that there are 3 reasons why PCO patients require vitamin D. So I've been giving it. And I was being warned by my friendly medical endocrinologist not to give too much because there is such a thing as an overdose or over effects. And when you say too much, how do you quantify it too much? I am wondering because I do a pre-treatment vitamin D3 assay before I start, and they are all deficient, so I give them 1,000 to 2,000, depends on how deficient they are. But since, and most of them have gestational diabetes ongoing because they are my infertile polycystic. So because of that warning, I'm kind of taken aback. How much is too much?
Yes. So it's a really good point you make, because oftentimes when people think about a vitamin or something that you need that's essential, they think, well, I just need more of it, more, and that's not the case. There is an optimal range, and that's why I mentioned the blood range between 40 to 60. So the cap was 60 nanograms per milliliter, was associated with the lowest all-cause mortality in 33 different meta-analyses over the course of whatever, it's 1966 to 2040 something years. So the reason the cutoff was 60 nanograms per milliliter is because as you started to go above that, it was actually associated with a higher all-cause mortality, much like below 40. So it was a U-shaped curve. So people that were very deficient were dying sooner of cancer and cardiovascular disease and respiratory dysfunction. And then the people that had really, really high vitamin D levels were also. So I think that partly, and a lot of that has actually to do with cardiovascular disease. I think that partly has to do with the fact that when you have adequate levels of vitamin D, you absorb about 40% more of your dietary calcium. So if you're absorbing a lot of dietary calcium, that's only good if you're also getting your vitamin K to make sure the calcium isn't sitting around and precipitating in your vascular system and forming a calcium precipitate, which it can do. And also vitamin D increases phosphorus absorption. So calcium and phosphorus together, it forms a precipitate immediately. And so if you don't have enough vitamin K around, you're going to potentially form that precipitate in the arteries. So I think that, to answer your question, I think the studies have shown that blood levels above 60 nanograms per milliliter is probably too much. But
pharmacologically, there's a paper on the toxicology of vitamin D that I was able to dig up. It's actually as high as 200 nanograms per mil. Yes. So you see, for example, in the tribes that have higher levels of vitamin D, some of their levels can go as high as 80 to 120. So those are the extremes of the values that they've found in these tribes. But generally, I try to keep the levels of vitamin D at around 50.
Just to add to that, so there's so many other things that are regulating vitamin D bioavailability, the conversion of it into a hormone. So some of these people that may and from these tribes that may have very, very high levels, we said 200 nanograms per mil?
Up to 120.
120, that's very high. They also may have high levels of, for example, vitamin D binding protein or these other things that are regulating the bioavailability of vitamin D, how much of it can actually be converted into the active hormone. So you have to be careful, just you never know, like this tribe may also have another, gene polymorphism that's making sure that not all of that vitamin D is being converted into the hormone. So it's kind of, there's lots of things to consider. But that's why I like looking at all-cause mortality studies, and there is a U-shaped curve, and I think it's important to look at that. Yeah.
So essentially, if you're less than 50, I wouldn't even be worrying about anything, because I know that your question is a clinical guidance. When do you start worrying that you have too much vitamin D?
Which is a better source of vitamin D, sun exposure or oral supplementation? And then second question is, can you quantify the amount or the length of exposure to sun? Can you quantify it into the number of IU as to the vitamin D in oral supplementation?
Okay, I guess I'll answer it first, and if you want to answer it, you can. So the first question is, what is better, making vitamin D3 from the sun or supplementing with vitamin D3? And I think that it really depends on many things. For example, making vitamin D3 from the sun is, and this kind of also answers your second question, 100% of the vitamin D3 that you make in your skin is bioavailable. So all of it can be bioavailable to be converted into the active hormone. So it's obviously superior. Only about 60% of the vitamin D that you take orally is bioavailable. The other 40% goes off with the chylomicrons. It's taken away, recycled back. So it's actually, almost half of what you're taking doesn't actually even get converted into 1,25-hydroxy vitamin D3. So, but the question is making it from the sun better? When we make vitamin D3 from the sun, there is a regulation process. When we have enough of it, the 7-dehydrocholesterol gets converted into something else. So our bodies have a very elegant way of making sure we don't have vitamin D3 toxicity from the sun. But you also have to remember that in order to make vitamin D3, you have to have UVB radiation exposed to your skin. And we know that UVB radiation also causes double-stranded breaks in your DNA. So, which can potentially lead to cancer and also skin aging. So I think if you can make it from the sun and get 15 minutes of sun exposure or 20 minutes a day, it's great. But again, there's so many factors regulating that age. I mean, if you tell a 60 or 70-year-old person to go out for 15 minutes, they're going to make 4 times less vitamin D than a 20-year-old. So you have to consider age and what their skin content is. So for example, Africans, they have to stay in the sun 10 times longer, close to 10 times longer, to make as much vitamin D3 as a light-skinned person, because the melanin pigment it's acting as sunscreen. It's literally sunscreen. So I think that there's lots of factors to consider when you're thinking about vitamin D3 from the sun versus supplementation. Personally, I am concerned with skin aging and also with double-stranded breaks. Like I mentioned, I measure DNA damage, and so I personally like to supplement, but I also like to get some sun exposure as well. So it's kind of a trade-off. I don't know.
Personally, I prefer sun exposure. The reason is there are many other benefits from staying out in the sun other than getting your vitamin D from UVB radiation. As to I'll address the second question that you had. Actually, last year I actually gave a chart because it's very hard to quantify sun exposure for just one chart, because sun exposure would be dependent on for example, the angle of the UVB, so it's on the latitude. It depends on so where you are, and then it depends on your skin color. So there's a chart for the skin color and then the latitude where you are, and there's a computation that is actually done in order for you to determine how many IUs of vitamin D you may be able to generate with X minutes of exposure to the sun. I think Dr. Hollick, who's done a lot of work on this, has a free app on his site where you could actually put in your latitude and your skin color and so on, and it will calculate for you how many minutes of sun exposure generates how many IUs of vitamin D.
Isn't it practical just to educate the people, even over the radio, that put out their arm and expose for 15 minutes? Will that be advisable?
Actually, last year, all of you laughed when I said that Philippines seems to have a cultural Stockholm syndrome. We want to be as white as our oppressors. So it's really a very hard thing. You can just say it over and over and it really never gets through.
Follow-up question. There is a rampant use of glutathione. Now, glutathione is rampantly used here as a whitening supplement. Will that have any effect on the synthesis of vitamin D?
Well, so first of all, glutathione supplementation doesn't actually... Glutathione gets destroyed in your gut and your stomach acid, and also there's no transporter for glutathione to get inside of cells. So supplementing with an actual glutathione does nothing unless it's liposomal. Liposomal glutathione is able to... It does not get destroyed by the stomach acid and the intestines, and also when it gets absorbed, it fuses with the cell membrane of a cell and is able to get in, which bypasses a transporter. So I think, for one, people supplementing with glutathione aren't really doing anything but taking a placebo pill. But I'm not sure how it would interfere with vitamin D.
How about intravenous? The
Oh, intravenous. I'm sorry. Okay. People do supplement with glutathione, so that's what I was. So people taking intravenous glutathione. What was your question?
Does it interfere with vitamin D metabolism? Does glutathione?
I have no idea. I'm not aware of this at all. Never. Yeah. I don't know how it would.
Because intravenous glutathione is rampantly done here, so it could be one reason why. Dr. Ted, could that be one reason?
I actually disagree with using it as a whitening agent, so my views are very strong, so I won't say anything.
You can follow Rhonda. She's active in the Twitter, podcast, and if you want the smoothie formula, it's on YouTube, right? Okay. So I'm here to give my thanks, but first of all, to all our friends in BioBalance, the doctors, thank you very much for attending. And of course, we'd like to thank our speaker. I have a certificate of appreciation here. I'll read it. This certificate is given to Rhonda Patrick, PhD, for sharing her expertise as resource speaker on micronutrients for the prevention of age-related diseases and brain dysfunction as part of the BioBalance Continuing Basic Medical Education Lecture Series, given on this 14th day of June, signed by the General Manager, me, and the Chief Science Officer, Theodore Atchacoso.
Thank you.
Thank you. Thank you. What? What's inside? That's hypoallergenic.